Meniere's disease. Introduction. It was first described by Prosper Meniere. It is also known as endolymphatic hydrops, which is a disorder of the inner ear, where the endolymphatic system is distended with endolymph. It is characterized by episodic vertigo, fluctuant deafness, which is of sensory neural type, and tinnitus. It is often associated with nausea and vomiting. It is also described as labyrinthine hydrops because of inner ear disease. Incidence. Incidence varies from 7.5 to 157 per 100,000 persons. It affects primarily Caucasians, with a mild female preponderance. About 10% of patients complaining of dizziness have Meniere's. Disease is commonly seen in the age group of 35 to 60 years. Males are affected more than females. Usually, the disease is unilateral, but the other ear may be affected after a few years. Bilateral disease develops in 47% of cases. Etiology. Exact cause of the disease is not yet known. The causative roles of viruses, like herpes simplex virus, cytomegalovirus, or varicella-zoster virus, remain uncertain. Genetic. Familial occurrence is seen in 10 to 20% of cases. There is an autosomal dominant mode of inheritance. Autoimmune. Certain genetically acquired major histocompatibility complexes, specifically human leukocyte antigens B8, DR3, and CW7, have been associated with Meniere's disease. Immunologically induced inflammation is seen. Allergy. Presence of immunoglobulin G, immunoglobulin A, and secondary component in the cells of the sac stroma. Hormonal. Vasomotor instability and ischemia. Psychosomatic. As the exact cause of Meniere's disease is not yet known, various theories have been postulated, such as food or inhalant allergy, autoimmune process, viral infection, herpes family, stress, vasomotor disturbance, sodium and water retention, endocrinial, hypothyroidism, oral fullness, tinnitus, fluctuating hearing loss, episodic vertigo, defective absorption by sac. 1. Defective absorption by endolymphatic sac. Normally, endolymph is carried by the endolymphatic duct to the endolymphatic sac where it is absorbed. Defective absorption by the sac may be responsible for raised pressure of endolymph. Experimental obstruction of the endolymphatic sac and its duct also produces hydrops. Ischemia of the sac has been observed in cases of Meniere's disease undergoing sac surgery, which indicates poor vascularity and thus poor absorption by the sac. Distension of membranous labyrinth leads to rupture of Reisner's membrane and thus mixing of perilymph with endolymph, which is thought to induce an attack of vertigo. 2. Vasomotor disturbance. There is sympathetic overactivity resulting in spasm of the internal auditory artery and its branches, thus interfering with the function of the cochlear or vestibular sensory neuroepithelium. This overactivity is responsible for deafness and vertigo. Anoxia of capillaries of stria vascularis also causes increased permeability, with transudation of fluid and increased production of endolymph. 3. Allergy. The offending allergen may be a foodstuff or an inhalant. In these cases, the inner ear acts as a shock organ, producing an excess of endolymph. Nearly 50% of patients with Meniere's disease have associated inhalant and/or food allergies. It's possible that Meniere's disease is multifactorial, resulting in the common endpoint of endolymphatic hydrops with a classical presentation. 4. Sodium and water retention. Excessive amounts of fluid are retained further, leading to endolymphatic hydrops. 5. Hypothyroidism. About 3% of cases of Meniere's disease are due to hypothyroidism. These cases benefit from thyroid replacement therapy. 6. Autoimmune and viral etiologies have also been suggested on the basis of experimental, laboratory, and clinical observations. Etiology of secondary endolymphatic hydrops. Secondary endolymphatic hydrops is known to be secondary to otic capsule diseases like congenital or acquired syphilis, otosclerosis, Paget's disease, and post-staphylectomy cases. Atypical Meniere's disease is a term that has been suggested to describe patients who complain of some symptoms of Meniere's, but not all the classical symptoms of the triad. Pathophysiology. The basic pathology in Meniere's disease is increased accumulation of fluid in the endolymphatic system, causing engorgement due to 1. Excessive endolymph production in the stria vascularis. 2. Decreased absorption of endolymph in the endolymphatic sac. Pathology. The main pathology is the distension of the endolymphatic system. Parasaccular ischemia and fibrosis lead to inadequate absorption of endolymph by the endolymphatic sac. Overaccumulation of endolymph at the expense of paralymphatic space results in the distortion of the membranous labyrinth. Alterations in the size of the lymphatic duct and sac, along with reductions in the tubular specializations of the lining of these structures, have been observed. Endolymphatic hydrops mainly occurs in pars inferior, that is cochlea, and saccule, and changes in pars superior, that is utricle, and semicircular canals are usually minimal. The basilar membrane gets distended into scala tympani. The dilatation of the cochlear duct is such that it may completely fill the scala vestibuli. There is marked bulging of Reisner's membrane, which may even herniate through the helicotrema into the apical part of scala tympani. Saccular distension can distort not only the utricle and semicircular canals, but can also come in contact with the Stapes foot plate. That can cause Hennebert's sign, where the patient has dizziness along with horizontal nystagmus. Hair cells and their neurons are usually spared. Membranous rupture can occur in any part of the inner ear, which allows leakage of potassium-rich endolymph into paralymph. The high concentration of potassium depolarizes the neurons and inactivates both vestibular and auditory neurons that results in vertigo, paralytic nystagmus, and deafness. Healing of membranes allows restitution of normal chemical and clinical status. Repeated membranous rupture and potassium exposure may lead to chronic deterioration in the functions of the inner ear. Clinical features. Cardinal symptoms of Meniere's disease are 1. Episodic vertigo, 2. Fluctuating hearing loss, 3. Tinnitus, and 4. A sense of fullness or pressure in the involved ear. The typical presentation consists of recurring attacks of spinning vertigo in the horizontal axis, usually for 2 to 3 hours, with tinnitus and ipsilateral hearing loss. Attack lasting more than a day is consistent with diagnosis. Vertigo attacks are generally preceded by an aura consisting of fullness in the ear, increasing tinnitus, and a decrease in hearing. Attacks may be sudden in onset without any warning or may occur in sleep, awakening the patient. Attacks may cease spontaneously after 2 years, 8 years, or may occur for 20 to 40 years. In the early phases of the disease, the patient may have either vestibular symptoms, like recurrent vestibulopathy, or auditory symptoms. Clusters of attacks are separated by long remissions. Patients can have single, sporadic attacks or periods of unrelenting recurring attacks. Emotional impact may be similar to major medical problems. Attacks are often accompanied by nausea, vomiting, diarrhea, or sweating. Vertigo is exacerbated with any head movement. Between the attacks, patient may be totally symptom-free or feel disequilibrium, lightheadedness, or tilt. Teleo phenomenon. It's a condition where loud sounds or noise produce vertigo and is due to the distended saccule lying against the stapes footplate. Hearing loss is fluctuating and progressive. It usually accompanies vertigo or may precede it. Hearing improves after the attack and may be normal during the periods of remission. This fluctuating nature of hearing loss is quite a characteristic symptom of the disease. With recurrent attacks, improvement in hearing during remission may not be complete. Some hearing loss is added in every attack, leading to slow and progressive deterioration of hearing, which is permanent. Distortion of sound. Some patients complain of distorted hearing. A tone of a particular frequency may appear normal in one ear and of a higher pitch in the other, leading to diplacosis. Music appears discordant. Intolerance to loud sounds. Patients of Meniere's disease cannot tolerate the amplification of sound due to the recruitment phenomenon. They are poor candidates for hearing aids. Tinnitus is non-pulsatile and may be whistling or roaring, continuous or intermittent. It becomes louder or changes pitch as an attack approaches and improves after the attack. Change in intensity and pitch of tinnitus may be the warning symptom of the attack. Nystagmus. The diseased ear cannot be determined just on the basis of the direction of nystagmus. The direction of horizontal nystagmus, which is the cardinal finding, varies over the course of the attack. In early irritative nystagmus, it is ipsilateral. In later paralytic nystagmus, we find it on the contralateral side. In late recovery, nystagmus is again ipsilateral. Investigations. Audiogram. Low-frequency fluctuating and progressive sensorineural hearing loss and a coincident non-changing high-frequency loss. Average pure tone loss of 50 decibels is noted. Profound deafness is rare. Peak at 2 kHz, tent-like audiogram is seen. In due course of time, hearing loss flattens. Recruitment is present in 56% of cases. A mean speech discrimination score of 53% is recorded. Staging. On the basis of pure tone average, 500, 1000, 2000, and 3000 Hz in decibels of the worst hearing level, audiogram, and the interval of 6 months before treatment, Meniere's disease has been graded into the following 4 stages. Stage 1, less than 25 decibels, hearing loss. Stage 2, 26 to 40 decibels, hearing loss. Stage 3, 41 to 70 decibels, hearing loss. Stage 4, more than 70 decibels, hearing loss. Glycerol test. Glycerol is a dehydrating agent. When given orally, it reduces end-of-lift pressure and thus causes an improvement in hearing. This glycerol dehydration test is performed by administering glycerol, flavored with orange juice or lime, by mouth, in a dose of 1.5 milliliters per kilogram. A pure tone audiogram and electrocochleography are carried out before ingestion of the dose, and again 1 to 2 hours later, it is repeated. The test is considered positive when a 25 decibel shift is seen at 3 consecutive frequencies, or 16% improvement in speech discrimination. Plasma osmolality should also be measured, since there can be no effect on the cochlea unless that rises by more than 10 milliosmoles per kilogram. A 15% improvement in pure tone audiometry is significant, and a decrease in summating potential-action potential ratio is seen. Dehydrating agents. Urea, glycerol, and furosemide produce measurable improvement in audiometric score, reduction in summating potential negativity, electrocochleography, and change in gain of vestibulo-ocular response to rotational stimulation. sensitivity and specificity vary widely. Vestibular function test. Caloric test. This is abnormal in about 75% of patients. The commonest pattern is a canal paresis, but a directional preponderance towards the normal ear, or a combination of reduced canal sensitivity and directional preponderance may also be found. Electronystagmography. It's now accepted as a routine investigation in vertigo patients. The caloric response is significantly reduced in 48 to 73.5% of cases. Complete loss occurs in 6 to 11%. Electrocochleography. Infrequently used. It shows the changes that are characteristic of, and probably diagnostic of, endolymphatic hydrops. There is a broadening of the summating potential action potential waveform due to a relative enhancement of the summating potential. Summating potential is larger and more negative due to the distension of the basilar membrane into scala tympani. The normal summating potential action potential ratio is around 20 summating potential action potentia. In an ear with hydrops, the ratio is often as high as 30%. In the action potential of cranial nerve 8, a reduction in amplitude is found. Brainstem evoked response audiometry. Measurement of the tiny physiological electrical events occurring in response to sound stimulation. Brainstem response stimuli in the form of clicks. These electrical potentials are picked up from the vertex by surface electrodes. Imaging. It is usually not required for the diagnosis. Following findings may be seen. Computed tomography scan. Hypoplasia of the endolymphatic sac and duct results in decreased visualization of vestibular aqueduct and reduction in paraaqueductal pneumatization. Reduced retrolabyrinthine bone might be a predisposing factor to disease. Magnetic resonance imaging. Significantly smaller and shorter endolymph drainage system. Gadolinium-enhanced magnetic resonance imaging. Enhancement of endolymphatic sac reflects inflammation of sac. Variants of Meniere's disease. 1. Cochlear hydrops. In this, only the cochlear symptoms and signs of Meniere's disease are present. Vertigo is absent. It is only after several years that vertigo will start its appearance. It is believed that in these cases, there is block at the level of ductus renuens, thereby confining the increased endolymph pressure to the cochlea only. 2. Vestibular hydrops. Patient gets typical attacks of episodic vertigo while cochlear functions remain normal. It is only with time that a typical picture of Meniere's disease will start to develop. Many of the cases of vestibular Meniere's disease are titled recurrent vestibulopathy, as endolymphatic hydrops cannot be demonstrated in the study of temporal bones in such cases. 3. Drop attacks. Tomarkin's autolytic crisis. In this, there is a sudden drop attack without loss of consciousness. There is no vertigo or fluctuations in hearing loss. Patient gets a feeling of having been pushed to the ground or polyaxed. It is an uncommon manifestation of Meniere's disease and occurs either in the early or late course of disease. Possible mechanism is deformation of the autolytic membrane of the utricle or saccule due to changes in the endolymphatic pressure. Acute utriculosaccular dysfunction may lead to inappropriate postural adjustment via vestibulospinal pathway. Other causes of drop spells include cardiogenic, vertebral basilar insufficiency, and migraine. 4. Lermoy syndrome. Here, symptoms of Meniere's disease are seen in reverse order. First, there is progressive deterioration of hearing, along with increased tinnitus, followed by an attack of vertigo. The hearing loss and tinnitus resolve dramatically with the onset of vertigo. Meniere's disease versus Meniere syndrome. Meniere's disease is an idiopathic condition, Meniere syndrome, though, resembling Meniere's disease clinically. It has episodic vertigo, fluctuating hearing loss, tinnitus, and ear fullness, results from a variety of conditions such as trauma, head injury or ear surgery, viral infections following measles or mumps, syphilis, congenital or late acquired, Cogan syndrome, autosclerosis or autoimmune disorders. It is also called secondary Meniere's disease. Diagnosis. Committee on Hearing and Equilibrium of the American Academy of Otolaryngology, Head and Neck Surgery, classified the diagnosis of Meniere's disease as follows. 1. Certain. Meniere's disease is confirmed by histopathology. 2. Definite. 2 or more definitive spontaneous episodes of vertigo lasting 20 minutes or longer. Audiometrically documented hearing loss on at least one occasion. Tinnitus or oral fullness in the affected ear. All other causes excluded. 3. Probable. 1 definitive episode of vertigo. Audiometrically documented hearing loss on at least one occasion. Tinnitus or oral fullness in the treated ear. Other causes excluded. 4. Possible. Episodic vertigo of Meniere's type without documented hearing loss, vestibular variant. Sensory neural hearing loss, fluctuating or fixed, with disequilibrium but without definitive episodes, cochlear variant. Other causes excluded. Medical treatment. The treatment of Meniere's disease or endolymphatic hydrops is mysterious because the precise etiology of the disease is unknown. Conservative measures are usually taken. 1. General measures. Reassurance. Explaining the nature of the disease and explaining all the details, especially during an acute attack, relieves the patient's anxiety. Lifestyle changes. Cessation of smoking. Nicotine causes vasospasm. Smoking should be completely stopped. For some patients, this may be the only treatment necessary, and relief of symptoms can be noticed. Low-salt diet is recommended. Patients should take a salt-free diet as far as possible. No extra salt should be permitted. Salt intake should not exceed 1.5 to 2 grams per day. Avoid excessive intake of water. Avoid too much tea, coffee, and alcohol. Avoiding stress is of utmost importance. Practicing mental relaxation exercises, meditation, and yoga help to deal with it. Avoid activities requiring good body balance. As the attack of Meniere's disease is abrupt, sometimes without any warning symptom, professions such as flying, underwater diving, or working at great heights should be avoided. Accidents are prone to occur during sudden episodes. 2. In acute attacks. Reassurance and psychological support to allay worry and anxiety. Bed rest with head supported on pillows to prevent excessive movements. Intravenous fluids and electrolyte administration to combat their loss due to vomiting. Vestibular sedatives are given to relieve vertigo and anxiety. They should be given intramuscular or parenteral if vomiting precludes oral use. Drugs given in acute episodes are prochlorperazine, Stemetil, promethazine thiaclate, avamine, dimenhydrinate, dramamine, and diazepam. Diazepam, Valium or Compos, 5 to 10 milligrams can be given intravenously. It has a high tranquilizing effect and also suppresses the activity of the medial vestibular nucleus. In a few patients, an acute attack can be stopped by atropine. 0.4 milligrams is given subcutaneously. Vasodilators. Vasodilators are used based on the hypothesis that ischemia of the stria vascularis may cause Meniere's disease. The rationale is to improve the metabolic function of a diseased ear. Inhalation of carbogen, 5% carbon dioxide with 95% oxygen, causes cerebral vasodilation and improves labyrinthine circulation. Intravenous histamine diphosphate, 2.75 milligrams in 500 milliliters glucose, show intravenous drip, isosorbide dinitrate, sonorazine, which is a calcium antagonist, and beta-histine, an oral histamine analog, helps in managing acute episodes, but is contraindicated in asthmatics, and they should not be given on an empty stomach. Beta-histine produces vasodilation of the capillaries, arterioles, and arterial venous arcades in the stria vascularis and spiral ligament, hence lowering endolymphatic pressure. The adverse side effects include tachycardia, disturbed cardiac rhythm, hypotension, hyperthermia, and bronchospasm. 3. Chronic phase. Dietary modifications like salt restriction, intermittent dehydration, and hyperosmolar dehydration should be started. Diuretics. Hyperosmotic diuretic isosorbide, acetazolamide, carbonic anhydrase inhibitor, sometimes diuretic furosemide, 40 milligrams tablet, taken on alternate days with potassium supplement, helps to control recurrent attacks, if not controlled by vasodilators or vestibular sedatives. Thiazide diuretics, hydrochlorothiazide, 12.5 milligrams daily, can also be used. Vasodilators. Quantitative improvement was not seen consistently with these medications. Histamine, beta-histine, piperine analog, euphorbine, nicotinic acid, adenosine triphosphate, and dipyridamole can be used. Beta-histine, Verdin, 8 to 16 milligrams thrice a day, given orally, also increases labyrinthine blood flow by releasing histamine in the body. Symptomatic medications. They are beneficial in reducing the symptoms and improving tolerance. Antivertiginous, antiemetics, sedatives, antidepressants, and psychiatric medication should be given in addition for supportive treatment. Propanthyline bromide. Probanthine, 15 milligrams 3 times a day, is found effective in some cases. It can be given alone or in combination with vasodilator and is quite effective. However, they're not preferred by many due to the side effects presented, as it's an antimuscarinic agent. Elimination of allergen. In cases of allergy, the causative allergen should be eliminated or desensitized. Anti-allergic medication is also given. Hormones. Endocrinal hypofunctioning, such as hypothyroidism, need appropriate replacement therapy. Other therapies like acupuncture, herbal remedies are tried by some. Bilateral Meniere's disease. Parenteral streptomycin. Streptomycin is primarily vestibulotoxic and usually leaves hearing unchanged, indicated only for incapacitating bilateral Meniere's disease. 1.5 to 3.5 grams per day until ice water response is absent. For 17.5 days average, 39 grams mean total dose. 20 grams total dose preserves some vestibular function, which decreases the disabling oscillopsia and vestibular ataxia. Immunosuppressant therapy can also be given, which includes giving steroids for a long time, chronic usage, non-steroidal immunosuppressants like methotrexate. Surgical treatment. The patients who don't respond to medical treatment, surgical procedures should be considered. Chemical labyrinthectomy has recently become popular in the treatment of patients with disabling vertigo, which is persistent and refractory to medical management. Intramuscular streptomycin is used for its ototoxic side effect. Intratympanic gentamicin allows a treatment of unilateral Meniere's disease without producing systemic toxicity or affecting the opposite ear. The round window membrane serves as the primary route of entry into the inner ear with annular ligament of the stapes, which serves as a secondary route. The solution may be used as a stock solution of 40 milligrams per cubic centimeter at a pH of 5.4, or it may be buffered to a pH of 6.4 by sterile 8.4% sodium bicarbonate to improve patient comfort. The position of the patient would be supine, with the head turned away from the treatment ear. The tympanic membrane is anesthetized with the application of absolute phenyl using a swab stick. About 0.5 cubic centimeter of solution of gentamicin is injected into the middle ear with a 25-gauge needle over the round window niche in the posterior-inferior quadrant of the tympanic membrane. The patient remains in this position for 30 minutes and is instructed not to swallow. We routinely schedule the injections weekly until treatment is effective. Gentamicin inner ear perfusion. Low dose of 10 milligrams per milliliter of gentamicin infusion at 5 microliters per hour for 10 days through a microcatheter placed in a round window niche is given. It is reported that vertigo is controlled in 95% while preserving hearing in 77%. There are hearing conservative and non-hearing conservative surgeries. In hearing conservative surgeries, there are non-vestibular and vestibular ablative surgeries, and in non-hearing conservative, there is vestibular ablative surgery. Let us discuss them in detail. 1. Hearing conservative non-vestibular ablative surgery. Endolymphatic sac decompression. Decompression of endolymphatic sac is done and may be combined with insertion of silastic sheeting, tubing, one-way valve, tube sponge, gelatin, or tissue stent. The drainage pathway is routed to the epidural space by incision of the back wall of the sac. 50 to 75% of patients have complete resolution of the vertigo. Cochleosacculotomy. When mechanical blockage of utricular and saccular ducts does not allow endolymph to reach endolymphatic sac, perforation of the saccule is done behind the oval window with a pick through the round window. 70% of patients have complete control of vertigo. Major drawbacks include recurrence and high incidence of hearing loss. Fick and Cody-Tack procedures. They create fistulas in the saccule via the oval window, similar to cochleosacculotomy. Transtympanic corticosteroid infusion of middle ear. 2. Hearing conservative vestibular ablative surgery. Vestibular neurectomy. About 95% of patients have complete resolution of vertigo while conserving hearing. The following approaches may be employed for the resection of the nerve: middle fossa approach, suboccipital approach, retrosigmoid approach. Cryosurgery. Ultrasonic destruction of the vestibular labyrinth is done where the cochlear function is preserved. Cochlear dialysis. Cochlear implantation. Bilateral severe to profound hearing loss is seen. 3. Non-hearing conservative vestibular ablative surgery. Labyrinthectomy. When serviceable hearing is absent and pure tone average is more than 60 decibels with speech discrimination less than 50%, labyrinthectomy can be done. Membranous labyrinth is completely destroyed either by opening through the lateral semicircular canal by transmastoid route or through the oval window by a transcanal approach. This gives relief from the attacks of vertigo. Ablation is performed with hypertonic saline. Translabyrinthine cochleovestibular neurectomy is done where the 8th cranial nerve is transected. Destruction of Scarpa's ganglion where the vestibular branch of vestibulocochlear nerve is performed. Other methods of surgical treatment include intermittent low-pressure pulse therapy, also known as Meniere device therapy. It's observed that intermittent positive pressure delivered to inner ear fluids brings relief from the symptoms of Meniere's disease. Along with the improvement in vertigo, tinnitus, and ear fullness, hearing may also improve. Intermittent positive pressure waves can be delivered through an instrument called a Meniere device, which has been approved by Food and Drug Administration. A prerequisite for such a therapy is to perform a myringotomy and insert a ventilation tube so that the device, when coupled to the external ear canal, can deliver pressure waves to the round window membrane via the ventilation tube. Pressure waves pass through the perilymph and cause a reduction in endolymph pressure by redistributing it through various communication channels, such as the endolymphatic sac or the blood vessels. Some believe they regulate secretion of endolymph by the stria vascularis. Self-administration of the treatment can be done at home by the patient. It may take a few months before complete remission of disease is obtained. Meniere device therapy has been recommended for patients who have failed medical treatment, and the surgical options are being considered. Differential diagnoses of Meniere's disease. Meniere's disease, which is an idiopathic lesion, is a clinical diagnosis. The conditions, which are included in Meniere syndrome or secondary Meniere's disease, can mimic the clinical features of Meniere's disease and should be kept in mind. 1. Migraine and basilar migraine. 2. Autoimmune disease of inner ear and otosclerosis. 3. Syphilis and Cogan syndrome. 4. Cardiogenic. 5. Vertebral basilar insufficiency. 6. Trauma, head injury or ear surgery. 7. Acoustic neuroma. 8. Benign paroxysmal positional vertigo. 9. Cervical spondylosis. 10. Labyrinthitis. 11. Perilymph fistula. That's all for the video. We'll see you next time.